Good afternoon, everyone, and welcome to this Kaleidoscope webinar all about primary care collaboration. Great to have you on the line today. We're going to run for about an hour and a fantastic topic to talk about. In health policy, we've all been talking for quite a long time about the importance of an enlarged role for primary care, and we know that the only way that that's going to happen is through greater collaboration between and within GP practices, which is going to be the topic of our conversation today. So my name is Richard Taunt. I work here at Kaleidoscope. Very pleased to be joined by Ben Gowland of Ockham, wearing a very fetching headpiece, Ben, I have to say.
Do you like that? Yeah, it makes you look professional.
It gives that sort of air of credibility. We'll believe everything you say, just that little bit of it. So thank you all for joining. Just to do some sort of housekeeping before we get going properly. We'd really like you to sort of join in and interact over the next hour. We're going to do this all by text. We're not going to bring you in by phone or by voice. But you'll see on GoToWebinar there's a little ask question function. I always think it looks a bit like a hairdryer. But you can use that, just put in any questions, and please do that as we go through. And we'd love to get your views, comments, questions. So tell us where we're going wrong or it's not entirely certain. Please use that function to bring us in. And if you can't get the question function to be working, please use please just email us. So my email address is richard@kaleidoscope.healthcare. I'll put that in the chat box in just a second. But try and use the question thing. If that's not working, email us, richard@kaleidoscope.healthcare. And it'd be great to discuss your questions. So I'll say again, we're not going to bring people in by voice, but please do send us your written comments. That would be great. We're also not going to go around and do introductions across everyone, just because of the variety of places people are dialing in from. But if you do want just to type a quick hello, say who you are, where you're joining from, and why you're particularly interested in the topic, again, just use the sort of ask question function for that. Put in your brief introduction, and we'll share that with the group. So please do that. So, without further ado, we're going to start with Ben talking us through the topic, why we're talking about it, what exactly we're working on, and why. So we're going to do that for the first 20 minutes or so. I might butt in occasionally, Ben, if that's okay, if there's sort of particular points to underline and reinforce, and then we'll just move into general discussion. But please do pop questions in throughout the session, put in your comments. We want this to be an interactive session, so please do that. We are also recording today, so that you may well be watching back. Hello if you are. And it will be going up on the Collaboration Fund website along with all the other information when we're finished. So I think that's all. If, again, any questions, pop them in the question function, send me an email if that's not working. And we'll try and sort you out. Excellent. Ben, over to you.
Thanks, Richard. And it's great to be part of this today. So my name's Ben Gowland. I'm a director at Ockham Healthcare, and we sort of specialise in supporting innovation in general practice. And we've worked with a number of individual practices as well as areas across the country to support collaboration and joint working between practices. I run a podcast. Some of you, I think I recognise some of the names from our subscriber list, so hopefully some of you will come across that. As Richard was just telling me before we started, we've just done our 70th episode of that, so dig it out on iTunes and have a look. And before I did Ockham Healthcare, I used to run a 70 practice GP federation and was the accountable officer of a CCG. So in this presentation, I'm going to be talking about collaborative working. So what is it? Why do we need it? What are the different ways of doing it? And why is it difficult? And then I'm going to talk about a program that we're starting up joint with Kaleidoscope about how we can support collaborative working locally and how that would work. So if we dig into the slides, Richard, can we move on to the first slide? Okay, so I thought there's quite a big question in terms of what is collaborative work, and it covers quite a range of different things. And I thought it might be helpful just to kick off by a few examples of collaborative working that are already in place across the country, and there are lots of different things. So, and it can range from some practices getting together and doing something jointly to some quite bigger, more intricate governance pieces. The sort of the purple links that you can see on the slides there, they're actually links to some of the podcast episodes that we've done with some of these areas where you can find out more detail if you're interested in it. And actually our most popular episode of the podcast is about St Austell Healthcare in St Austell, where what happened was they're a town of 4 practices, and one of the practices basically had to return their list. And so the other practices had to work out how they were going to respond to this crisis in their local town. And the outcome of that was that they decided not just to work collaboratively, but to fully merge. And not only merge, but to change totally the way that they worked. They opened what they call an acute care hub and redesigned the whole format of their buildings. And they did a whole load of change all in less than a year. And it's a real fascinating story about the scale of things that can be achieved in quite a short space of time when the incentives and the environment is right. Equally, we've been following the progress of our health partnership in Birmingham, and some of you will have heard about them. They're a super practice, whatever that is. And so essentially, there are a number of practices. Initially, it was 32. I just expanded recently, where the practices dissolved their existing partnerships and created a new partnership. So what that means in practice is that the 32 individual practices are still operating as profit centres with their own ways of operating, but technically they're one partnership, and they have a central function whose job it is to help them both reduce their costs and operate better in the new world. And it's quite a fascinating journey, and we sort of talk to them every 6 months and have been watching how that's been developing, so you can get more information about that. Collaborative working doesn't have to mean merger. So Richard, if we go on to the next slide, often when people talk about collaborative working, they're talking about federations, and there are good and bad examples of federations. I'd say one of the better examples that I've come across is the City and Hackney GP Federation in North London, and that's where standard sort of federation set up whereby the member practices will pay a fee. There's a central team, and they provide support and develop new services, and have done a set of things that can add real value to the practices that they're working with. Now, Helen Parker may well be in the audience, I'm not sure, but if she is, hello, Helen. I'm sure she'll be able to tell us more about this later, but I've been talking to her recently about a network of practices. The Pinnacle Network is part of the Midlands Health Network in New Zealand, and it's a really fascinating case study about what can be achieved by practices working together. So they created an entity of the network, and the network does a range of different things, including running is the equivalent of our APMS contracts for practices that were put out to tender. It's created its own income streams, and what that's given it is a bit of financial independence that means it can now provide dedicated support to its member practices. So the network itself is set up with this explicit purpose of supporting GP practices, and they, as part of the network, have then created what they call the Healthcare Home, which is a program which basically says this is what we think general practice will look like in the future, and the network itself provides the support to those practices to deliver it. So they're just some samples in terms of, okay, this is what collaborative working could look like. We've also worked with towns where it's been at a really early stage where basically the practices just weren't talking, and how do you get practices that aren't talking to actually start to think about working together? Or equally where you've got a number of federations in an area, and how can you get the federations working so that they feel like they're on the same team rather than competing against each other. So there's lots of different aspects to it. if we look at the next slide, I guess the question that is the starting point always for me is, so why do we need collaborative working? And it feels like there are two different drivers for collaborative working. So there's the drivers that comes from the practices themselves and the drivers that comes from the system, often sort of via the CCG. Now for practices, the sort of the drive comes from the challenges that lots of practices are experiencing at present. So those challenges are focused around workload, around recruitment, and around finances, and they sort of are slightly different in each different area, but often they'll manifest at the point at which a practice not only can't recruit a GP but can't recruit enough GP partners. There's concerns about the finances of the practice, or the ability of the practice to cope with the workload that's there, and a sense that the practice as the entity in the size that it is can't carry on. And a lot of the collaborative working that I've seen recently has often been driven by a crisis in one or more of the practices, actually working out we can't carry on doing this on our own, and so have to do this in collaboration with others, and working out what that collaboration would need to be. Not everywhere is in crisis, so the places that aren't quite in crisis, there are practices who can see that crisis might not be there yet, but they can see it happening at some point in the future. And so part of collaboration sometimes is for more forward-thinking areas to say, well, we don't want to wait until we get into that state, into that crisis state, and by collaborating with others, we can put ourselves in a position where we can avoid that happening in future. So there is this whole drive for collaboration that comes from the position that general practice is in at present. On the next slide, at the same time, there's a sort of pressure from the system for collaborative working between practices. If you talk to a lot of commentators on the NHS, or people who look at the NHS and try and make sense of it, they'll say, well, the obvious thing is for GP practice to operate at scale and to operate together. And there's a kind of pressure for it to happen because on a policy side, I think people feel like it's a good thing. Linked, I guess, to the push to have extended access, which is a sort of political priority that we've seen over the last few years, and increasingly is going to be there over the next couple of years. And then a lot of the sustainability and transformation plans, or the STPs, are sort of built on this sense of out-of-hospital care, which has a bedrock of general practices operating at scale. And so part of the challenge of collaborative working is it can't be imposed on practices. And so it puts CCGs often, particularly CCGs who've taken on delegated commissioning, in quite a difficult position where they have a pressure to enable collaborative working to happen across their practices, but feeling that they can't directly influence, just because of the independent practitioner status that general practice has in terms of making that happen. So quite a lot of the keys to working through how we'll make collaborative working happen in practice is how do you bring those two things, the sort of bottom-up need of the practices, together with the sort of system strategy and the desire to move into new ways of working across the wider system together.
And Ben, I'm going to jump in there if that's okay, because I think there's a really important point there about this can't be imposed. This is important, and lots of people are going to want to see it happen. But I suppose the old policy maker in me, there's a sort of a bit of a cynic which says, you know, if it's going to deliver such benefits, why should people have a choice? Have you seen attempts where people have tried to push collaborative working in that top-down way and not delivering the results? What happens if actually you break your rule and you do try and impose this?
Yeah, I think it's it's interesting. If you look at, if we go on to the next slide, Richard, because I pick up some of that, which is, collaborative working or general practice working at scale isn't actually a solution in itself. So simply by having a federation or being a large merger practice or by groups of practices meeting in itself doesn't necessarily bring about benefits, but what it can do is be an enabler for other benefits to be delivered. Now, if and for the extent of those benefits to actually be delivered, then it requires the engagement and buy-in of the practices who are working together. And where it's imposed on practices and practices aren't bought into it, then it restricts the amount of things that the collaboration itself can deliver. I mean, I think it's quite important to say there are numerous examples across the country. Now, there's a couple there where federations and attempts to operate at scale general practice have failed. So where federations haven't necessarily managed risks in the way that potentially it could have been managed. And part of that comes out of the fact that historically federations were developed, and if you think back 10 years, it was kind of secondary care versus primary care, and could primary care deliver services that secondary care was currently providing and do it cheaper, almost like in competition. And the idea of a federation was more that it would be like a separate income stream that could support practices. But with all the problems that general practice has experienced over recent years, that mindset for collaboration between practices and operating at scale has changed, because you can't have this gap, this distance between the collaboration activity, between the work across practices and the core business of the individual practices, because in order for the collaboration activity to have an impact, it has to be directly linked to the core business of the member practices. And it kind of is why there's been more of a shift to super practices, or this idea of like practice chains, and kind of away from federations, because federations creates a second overhead in terms of the management structure for that federation, which also has to be then paid for out of the work of the collaboration. And it sometimes can also feel a bit like a competition between the federation and the individual practices. So, for example, instead of the enhanced services being offered to the individual practices, they're now delivered by the federation, and you get how that's better for the commissioner, but you can see how actually individual member practice can potentially lose out on that. So it's interesting that some of the federations, some of the bigger and very successful federations like City and Hackney and Suffolk have actually talked about is the next step on their journey to go from being a federation to being a super practice. And it's tough because the places that have had federations historically, it's hard to reinvent yourself as something different with a different relationship with its member practices. And we've worked with a couple of areas to try and look at ways that they potentially could do that. If we just look at the next slide, Richard, I mean, one of the things that I get asked a lot is, is it better to merge or be in a federation? And I guess, again, there's no right answer to that. It always depends on the context and the problems that people are trying to solve. But I guess the big difference is mergers keep the overhead costs, decision making, and control tight, but they're really hard to get in place. Whereas federations and networks operationally can be difficult. They don't have clear contracts, but they're quite easy to set up. And so you have this quite big difference between the two. And you can see why often places look at federations or networks as a step to a kind of closer joint working, just because of the challenges of making merger, particularly any kind of merger at scale, actually happen. So if we look at, on the next slide, Richard, why collaboration is difficult. It's difficult in different places for different reasons. So for some places I've been to, the practices aren't really speaking to each other. Things happen and they've happened over 60, 70 years, and people have been in place for a long time, and there's a kind of, this practice doesn't talk to that practice, and there's often a history that gets in the way of collaborative working. And equally, there are some practices that, despite the challenges that general practice as a whole is facing, are actually doing really well, thanks. And so what they don't want is anything to get in the way of the success that they feel like they're having now. So you often get one or two practices who just don't want, not only don't want to be part of collaboration, they don't want collaboration to happen around them, because then it'll feel like more of a threat to what they're doing. And sometimes it's not practices, it's specific individuals. And it can take quite a long time in some places to get round specific individuals. And actually, if you talk to some places, they'll say, well, when Dr. X retires, then potentially we might be able to do something. But until then, we just don't think it's possible. In the sort of bottom line of collaboration is this unit of currency of trust. That the higher the level of trust between the different people who are collaborating, then the more successful it's likely to be. And that initial challenge is, how do you get the level of trust to be high enough that people are prepared to take the first steps? And we've done quite a bit of work in terms of working through how can you actually go from a place where there's zero trust to enough trust to actually get things off the ground. And so following on from that is, you need the right GP, in particular the right GP, leading this. And sometimes that can take some time to persuade them that it's right. And equally, you can have GPs who aren't the right GPs putting their hands forward, and you know that if you go with that, that actually that isn't going to get you where you need to be. So there's this whole issue about building the trust to where it needs to be, and then making sure you've got the right people in place, actually taking that forward. So what we've got, and if we click onto the next slide, is we've been putting together a program which we call Primary Care Collaboration, and it's to help areas support joint working between practices. And it can be for practices who are at any stage, whether they've already got off the ground and want to work out how they get to the next level, or they're just stuck at ground zero and don't know how to move forward. There are a number of different components to the program that I'll quickly talk about. So it's a process based on evidence. It's an evidence-based change process to actually make the collaboration happen. It's not each individual just learning on their own. It's part of being part of a program where people learn together. So it's a 6-month program where we have day-long face-to-face events where people are part of a learning group going through the same thing, and where there's virtual support throughout the 6-month period to support individual teams. And so for each participant, they get the structure, tools and support they need to make that collaboration happen. I'll just go through really quickly each of those elements. So Richard, on the next slide, we've got a quote which I love, this quote, which is essentially, and I'll read it to you because I think it's really important. So, by far the biggest mistake people make when trying to change organisations is to plunge ahead without establishing a high enough sense of urgency in fellow managers and employees. This error is fatal because transformations always fail to achieve their objectives when complacency levels are high. So really commonly in the setup of federations and collaborative working, you'll get one or maybe two really enthusiastic, keen individuals, and they try and work on a principle of no active resistance equals positive support. And so what they'll do is they say, well, we're doing this, and as long as no one's actually getting in the way and stopping them doing it, then they'll get it up and running. And the problem is, because the people who are involved, the practices who are involved, don't understand why they're doing it, it's not clear enough, the rationale for their involvement, then you get into these problems of engagement of practices and of GPs really quickly with the work. And so it's, even though it feels slower, it's actually much better to spend the time establishing the need and the rationale for the collaboration before you jump into the process of should we be a super practice, or should we set up a federation, or what's the sort of governance or technical nature of what it is that we're trying to set up. So on the next slide, we start by understanding where each place is. And so the way I look at it is everyone is starting in sort of one of three places. So either there's like no history, so you just got to start things happening. The ball's never got rolling. There's places where it's worse than that, because in the past they've tried to do some stuff and unfortunately it didn't work out, or the federation went bust, or there was a massive fallout, and so you're sort of below zero and you've actually got to get to zero before you can even start to move it forward. Or there are things that have started, there's pockets of things that have started in the past, and there's this need to sort of pull them together and actually move it on to the next level. And even really innovative GPs are thinking, well, we've got this far, but where do we go next to really fulfill what we see as the potential for collaboration between our practices? And so what we do through the program is bring in this sense of how do you create this sense of urgency across from where you are now. So you've established a need that people can be excited about the possibilities, and you sort of build excitement about what it is that potentially can be done in the future. And we do a lot of building in what other people are doing around the country, what the different places, both in this country and in others, have been doing to take this forward. So if you look on the next slide, once you've got that sense of urgency, so you're clear on why you're doing it, we then get into how do you make sure you've got the right people leading this and you've got the right infrastructure. And often that, recently we found increasingly that's been about how do you facilitate a dialogue between the CCG or the STP and the groups of practices. And the groups of practices often aren't great at that type of communication, and often they find by getting support in that, they can be helped to get resources to transfer across to get them off the ground. And that being a two-way, mutually supportive process can really help make things happen. We work to support places have this vision. So what is it we're trying to achieve? And that happens in different places across in different areas, and it looks different. So I was talking about New Zealand, and if Helen's around, I'm sure she could talk about it a bit, but so that they're really, really clear that their vision is to support local GP practices. In other places, I was talking to the guys in Hampshire, it's about integration and about bringing community services and general practice service provision together in order to best meet the needs of the local population. So there can be really different visions as to what people want to achieve by through the collaboration. And the key with the vision is making sure not just that it's written on a piece of paper, but there are ways of being clear with not just the member practices, but the local population and everyone that this is what we're doing and this is why we're doing it, and getting people excited about that. And that, from my own experience and talking to others, that not being able to communicate effectively can actually build distance between quickly the collaborative activities and the core practices. But if you've got that currency of trust high enough, then often the practice will say, look, you just get on with it, we trust you, we know what you're going to do. And we're talking to Mark Newbold at our health partnership, he talks about they've got that trust, and so the practice say, look, don't keep talking to us, get on with doing the work for us, because that's what we actually need. And then through the program, we help people go from, okay, we're clear what we're going to do, but how do we actually get it to happen in practice? And how do we have this right balance between delivering the benefits of collaboration and making them happen in practice, and some of the governance aspects about creating different organizational forms, and how do you balance them right so they're both supporting each other rather than one taking over and getting in the way of what's needing to be happened. So that's the sort of process we follow. On the next slide, we've got this idea of action learning groups. So, okay, we've worked with lots of places and we've done lots of support for collaboration between practices, but some of the really great learning about a process that's done in this way with groups and individuals from different areas is that you can learn from each other. And so part of the program is that there's going to be action learning groups where you'll be in a small group of 8 to 10 people from different areas who will share the journey that they're on, will help each other with problem solving, and gives participants a place where they can share what they're thinking and the ideas they've got, and actually work that through with others who are going through the same process to actually test out what's going to work. And equally, the sort of peer group can help hold each other to account. So, I said I'm going to do this by the next time we meet, and have you done it? And that sort of holding to account can be really helpful in terms of ensuring progress at a faster rate than otherwise you would have. Then the third aspect, Richard, on the next slide, is around virtual support. So the whole period of time, we've got a website that's dedicated to the program, where, as well as access to existing case studies and examples of practice that's going on around the country, we'll have a set of things that we do like this, like webinars and other things, to support participants with the program as it goes through. So finally from me, so just the program itself, Richard, on the next slide, the details of the program. So who's the program for? So the program's for anyone whose job it is really to support collaboration between practices. So that could be GP leads, people in CCGs, federation leads, people whose job it is within STPs, anyone tasked with enabling collaboration between practices. It's a 6-month program. It's going to start in the autumn. We've got 20 places in each cohort, and we're funding that. So the funding comes through the Kaleidoscope's collaboration funder, and Richard will say a little bit about that in a minute. But essentially the cost is $3,500 per individual, and but we've got a 10% discount available for the first 5 people to register. Registration's only open today for the program. So I've spoken for, I think, a little bit too long, so I will stop there and hand back to Richard.
Ben, thank you very much. I think the definition of talking too long is when everyone sort of got bored and made a cup of tea. And well, I certainly haven't, and I'm sure others who've just joined on the line haven't also. Ben, thank you. That was a fantastic run through. I'm going to say a little bit about the sort of the Kaleidoscope role here and the collaboration funder way of funding this. But we'd love to hear your sort of questions, views, observations on the program, on Ben's talk. So please do use that ask question function and send them through. But just to say a bit more about Kaleidoscope. So Kaleidoscope, we're a social enterprise set up to bring people together to improve health and care. So how you best support collaborative relationships is our lifeblood. It's what we're here to do, and really excited to be working with Ben on this program. And I think I'll take exactly sort of mirror something Ben said earlier on, that your baseline currency to get any collaboration working isn't the structure, it isn't the Gantt chart, it isn't the sort of the program manager with a clipboard. It's about trust and how you build trust amongst different groups where you may have a history of those relationships not working. And so one of the key things we're really keen to think about in constructing the program is that actually the values and principles which we see as so important in the delivery of collaborative working in primary care around trust and relationships and learning amongst a community, not just on your own. We're looking to directly role model in how this program will be delivered. And so I was thinking as Ben was going through, sort of who are the ideal people we'd like to join with on this program. And for me, and Ben might want to come in on this as well, it is people who are dealing with this challenge, absolutely, but really want to learn in a collaborative way. And so we've already thought through and thinking through further how we make sure that that time we get to spend face to face, but also virtually as part of the program, we can do in creating sort of a safe culture where people are really feel able and welcome to bring some of their really knotty challenges and have those supported, have solutions to those supported by the wider group. So that the ideal participant would be with someone who would want to come and learn from some of the experience we have at Kaleidoscope and Ben has at Ockham, but more than that, are looking to learn from their peers too. So if that's you, we'd absolutely love to hear from you. Just a quick bit about Collaboration Funder, and I'm already seeing questions coming through, so thank you. So when Ben and I started to have conversations about this project, what we realised is that this challenge is one which so many areas are struggling with, and so what we were trying to think about was how do we create a program which can be co-funded by people with this issue, rather than us going around and talking to people individually. And this essentially is what Collaboration Funder does. It's a website, it's a platform which enables people to co-fund programs of work across health and care, and then come together to learn. So it's really quite a simple idea. It's almost a bit like crowdfunding, if you like. We're looking for 20 people to each fund a 20th of the cost of the program. And so if you go onto the website, you'll be able to see that if you are interested, all you need to do is email us and say, this sounds great, we're really keen to be involved, and we'll send you a sort of initial partnership agreement to sign on the dotted line, and then we go from there. We do have this special offer, 10% discount for the first 5 registrants. We're looking for 20 participants for that first cohort.
I mean, just to say, Richard, on that. I mean, I think that was the thing that attracted me to this whole model. Is often we get often it's CCGs who want support with how do we get collaborative working happening in our area, and it felt like a much better model if we could have a way of actually supporting the individuals in those areas to do it themselves, and then share that learning with other places. And until there was a model like this, you basically were reliant on a national program being developed. But I guess what this does is it creates a program that people can participate in without it necessarily being nationally prescribed.
We haven't got a tagline for Collaboration Funder, but if we did, it's a bit like a national program, but without all of that rubbish you associate with national programs. Could be it. Thank you, Ben. Questions starting to come through, and Helen, thanks for kicking us off. And Helen, I imagine you're joining us from the other side of the world, so thank you very much for that. Helen saying, hi Ben, a collaborative structure also facilitates a stronger single voice for the providers in the system, and therefore influence. Ben, is that your take?
Yeah, definitely. So I think particularly when you're looking for collaboration between practices who aren't necessarily in that crisis point yet, and you're trying to work through with them what's the value in collaboration between those practices, a really important point is that general practice needs a bigger say in the system. It needs I mean, we saw recently the nationally they want each general practice to say that it's on black alert, and I think that's a kind of reaction to the emails that come from the hospitals, via the CCGs to every practice saying the hospital's on black alert, and the practice thinking, well, I'm on, I couldn't be any busier, and yet I can't tell anybody that I'm that busy. And there's this feeling that they don't have a voice in the system. And I think, so not only being able to voice the challenges and the problems that the practices individually and collectively are facing, but also to be actively at the table, articulating what's needed in general practice and to support the role of general practice going forward. And I've spoken quite a bit to Tracy Bell in Manchester about general practice in the whole devolution project that's going on there, and she talks really powerfully about how it was really important to get the general practice provider voice, not via CCGs, so not via commissioners who've got a set of other things that they're also responsible and accountable for, but GPs as provider, and as within a collaborative structure or as bigger entities, they're much more able to have a clearer voice. And the other thing they can get is that capacity to have the time and so someone whose job it is to actually form partnerships and to have that voice. So I was talking to Jonathan Cope, who's the Pulse GP of the Year. For those of you who know him, he's a really great guy. He's the lead GP at Beacon Medical Group on the South Coast, and they were 30,000. They're just merging to become 60,000, and his clinical time has been reduced so that he, as the sort of lead partner, can have time to build relationships and to have the types of voices that Helen's talking about in the wider system. And he talks about the real value that that's brought to the practice, because they've been able to develop a whole set of partnerships, right from research partnerships to partnerships with pharma companies to partnerships with the local community, that have all added value to both the practice and the offering they're able to make to their patients.
Ben, thanks very much, and Helen, great point. And just, Ben, to pick up your paean of praise to Jonathan Cope, who we worked with as part of our recent event series, Collaboration Know-How, looking at provider collaboration across the NHS. I think, Ben, what struck me about Jonathan, the work that they were doing there, is that he'd been able to sort of successfully make the case to his fellow partners about the benefits which would come from these collaborations. And I think actually one of the, Ben, you correct me if I'm wrong, I think part of what we'd really like to get into in the program is being able to make really clear what those set of benefits which can come from collaboration look like, and how practices and CCGs can improve across a whole range of fronts through sort of a greater focus on collaboration.
So the other thing to say is that not everywhere has got a Jonathan. Do you see what I mean? So the challenge for some places is that they don't have an individual GP who's got that natural leadership partnership capability. And so part of what we offer through the program is support for some of those individuals to develop those skills and become more able to take that on, because without that really influential local leader, these things are really hard to get the pace that they need.
So Ben, that's a really interesting point, which actually came up in that Collaboration Know-How event, which we held where Jonathan was there. And David Dalton was speaking, and he was asked a question about, isn't collaboration just hampered by the wider system? Isn't what we're really talking about? We need the system incentives to change, and then we'll be able to collaborate. We'll be free to collaborate. And David actually made a really interesting point where he said, I don't think that is the main issue. And his take was actually the biggest impediment to collaboration in acute care, and Ben, be interested to get your view about whether this holds for primary care, is actually people like him who actually go into collaborations thinking, do I win or lose from this? Rather than thinking, how can I better serve my local population? And so that moving beyond that sort of that win-lose dynamic certainly was David's take about sort of success in acute collaboration. Ben, what's your take in terms of how that plays out in primary care?
Well, it's kind of linked, but I think if you talk to people who are involved in mergers of GP practices, the thing that they would say is the thing that can determine the success of those mergers, or the thing that would get in the way of those mergers, is the extent to which the different parties have the same set of values. So have they got values in common, or are the values different? And we do some things actually to sort of test those values out. So is the most important thing to the practice the drawings that they're going to be taking back, or is it the ability to provide a range of services to their local population, or is it autonomy and control over their own future? And it's not that one's right and one's wrong, but it's about how do you create a shared set of values. And so for me, part of the work is that there are assumptions about people's values. So, a practice will say, well, the practice down the road is only interested in money. And that often isn't true. It's a perception about them. And so how do you get past that is really important. The other sort of thing I think that gets in the way of collaboration is sometimes practices will say, oh, well, we can't because the commissioners won't let us and the commissioners aren't supporting us. And so there's this kind of need to sort of differentiate between what's in the control of the people trying to collaborate, i.e. things that they don't need any permission or special resources for, and things that are out of the control where they would need a business case and that would need to be approved. And it's kind of, they can't directly do it, just go ahead. And I remember when we started NEN, which was a 70 practice federation, the way we got that off the ground was by doing some things that were just in our control, that no one could stop us doing them, that actually just doing some things builds some trust of itself. And so that's really important in getting the collaboration off the ground.
Ben, really nice point. And question coming through from Richard Vigley. Richard, hello, hope you're well. And it does make me realise we've gone 45 minutes into our webinar. We haven't mentioned the Q word, Ben, which I think we've bad for both of us. But Richard's saying, hi Ben, the average GP is usually focused on how they provide quality, there's the Q, quality healthcare to their patients. Can you give any examples of some of the benefits of collaboration in the consulting room? Great question, Richard. Ben.
Yeah, so I actually think that needs to be the starting point, really. So if it was that point that collaboration in itself isn't a benefit, collaboration is an enabler to deliver other benefits. Now, what working together can do is it can reduce risk of making investments because it's spread over a bigger area. So practices that are collaborating have often found that they can move much more quickly in terms of testing and introducing new roles. So whether that's pharmacists or physiotherapists working in practice. Some places have been able to develop visiting services, so paramedic-led visiting services working across groups of practices, and obviously paramedics can't see all patients and do all visits because some are palliative care patients or patients that GPs need to see themselves, but they found it's between 60 and 70% of visits can be undertaken by the paramedic service, and they can ring up from the home to the relevant GP, and then as practices have worked together and got bigger, if you take, like, for example, Jonathan Cope's practice at Beacon Medical Group, but there's a number of other examples, and we've got this actually on our website, where they've been able to move, when they've got maybe over 20,000 population, they've got at least 3 buildings, they've been able to move sometimes to different systems of managing on-the-day demand, so that the on-the-day demand is delivered from one place, including a whole range of different roles, which enables access to be improved, the service to those patients to be improved, and then the service to the other patients, because longer consultation times can be delivered in the other sites, and the sort of mental health of the GPs improves as well, because they're getting this balance between quite intense on the day demand stuff plus the time to do the other work as well. So I think what the collaboration does is it provides opportunities and scale to be able to make some of these bigger changes in practice that practices often can't do on their own.
Ben, thank you, and a really nice point coming through from Helen, just on that, saying benchmarking by GP in a spirit of collaboration can drive up quality of care in consultation. Ben, is that something which you've seen, getting that peer review, but within that spirit of learning and collaboration rather than competition and adversity?
Yeah, I mean, anyone who's worked in a CCG or with a CCG will have tried to do some sort of collaboration, sort of peer review between practices. I think building the level of trust between between individual GPs, and not just between practice, I think you're talking between individual GPs, enables GPs to be much happier to do the peer review, to sort of share their own practice and to learn from others. And so there's this if it's done in the spirit of not trying to catch people out, but in terms of this is about education and about improving the quality of services, then it can be a real powerful thing. And I think the point about the collaboration is that it's built on a higher level of trust, and so it can have more impact than when you're just trying to impose it on people who don't really trust each other.
Thanks, Ben. Again, welcome further comments and questions as we go through. Ben, I was just going to rewind us to a bit you mentioned in the presentation, which people might have been sort of wondering exactly what that would look like. You're saying that the program is going to be a set of face-to-face events, and we're going to do virtual support, and we're going to tailor that support as much as we possibly can to the needs of each participant. Do you want to say a bit more, Ben, about our thinking there and how that would work out in practice?
Yeah, so I've worked in a whole load of different areas, and the thing that struck me is every area is different, and the place that people are starting from is different. So you can't, even when you're following a change process, you can't use a templated approach. You can't use a one size fits all approach. So what it means is we work really hard to make sure for each person joining the program that we tailor the content so that it's relevant to where they are now, so that there's not parts of it where you think, well, we've already done that, so we don't really need to worry about that stuff. It's about understanding how they can apply the different parts of it to where they are now. So just to give an example, we were doing some work with an area where there were 3 historic federations, and what they were looking at was how could we come together to form one federation that could have a stronger voice and be better positioned in terms of the access stuff that was coming in the local area. And of course, they still needed to do quite a bit about of the work on being clear about why they were doing the change, about creating the vision for the future. But that looked very different for them from a different place where there was no history, and there were just 2 or 3 comfortable practices and a couple of practices that had real challenges, to creating a rationale for that group. And so it's about saying wherever you are, it's creating a change process that will work for you in the situation that you're in.
Ben, thank you very much. And we're talking about a reasonably small program here. It's 20 participants, so this personalised approach to learning and sport is something which we're really keen to focus on. We're as always, time is against us. So we've got 8 minutes or so left, so please do send to comments, questions as they're going to you. Great point made by sort of Adrian. Adrian, thanks for joining. Saying, Ben, do you have a sense of optimum scale? And Ben, you've talked a lot about how collaboration in itself isn't the answer. It's not that you just get this model off the shelf and you're done. Does that apply to scale as well, or is there sort of a coalescing around the optimum size for provider collaboration?
Yeah, I'd love to know what Adrian is. I get, every time I meet a accountant who works with general practice, they ask me this question. So tell me, he says, all right, you told me there's no right answer, but what is the actual optimum scale? And apologies, Adrian, if you're not an accountant. So it's a really difficult question. So if you talk to Mark Newbold, who's the managing director at Our Health Partnership, he was really clear that at 130,000 population, he didn't think that they had the critical mass to deliver the benefits that they were seeking to achieve. Now, you've got to understand what they're talking about is how do we deliver genuine economies of scale across multiple practices? How do we create sufficient infrastructure that we can develop around all our member practices? So that might be like call centres and things like that. And so he would say, 250,000 you need to be getting to get some of those benefits. Now, the thing that I have found equally is if you're building things around trust, that the more people who are involved, the harder it is to keep that currency strong. So when I was at NEN, we were 700,000 as a federation, and we worked, subgroups of that population. And when we were kind of 50 to 70,000, there was really high engagement from member practices, really high local ownership, more diversity. And when we shifted that to 200, 250,000, we lost a lot of that engagement because the people in the room didn't feel like they knew each other. So I guess what I'm saying again is it depends what you're trying to do with the collaboration venture in the first place, and it will be different for each place. If you're trying to deliver, genuine economies of scales that will fall into the business of the practice, then it might be just the bigger the better is the answer. If what you're trying to do is create something that can deliver joined up services, that can partner with the community trust, that can have a real place-based approach, it might be that it needs to mirror the size of the local community. And if that's 30 or 50 or 70,000, then that might be right. So there will be a right answer, but it will be a right answer for you, and it'll be a right answer for your local circumstances. And we can help you work through what that's going to be, but there isn't a, it should be this number or it should be that number. I'm really sorry.
Ben, thank you very much indeed. So things we've learned in this webinar are, Adrian, you're not an accountant, you're a GP and a commissioner. Thank you for clarifying.
Sorry, Adrian.
And also for clarifying that some of your best friends and colleagues are accountants. That's great to know. It's a really interesting discussion there. And just to go back to the conversation we're having in response to Helen's question earlier, I'm just aware of time, so do put in any last questions if you've got them. But we're talking about how do you create that collaborative spirit across practices, and Helen came back and said, look, we do this in lots of ways, but summarised by creating time out for practice staff to meet and talk informally, and then come back later say, and we have New Zealand wine. So look, I'm sure that's a turbo chance.
Yeah, that's part of the programme, Richard. We'll get some New Zealand wine.
Well, look, we're interested in co-designing this, so if that's the key, then we might come back on that. But Helen, I'll just put back on the message. That's certainly that creating that space for getting to know our colleagues as people as much as professionals certainly tallies a lot with what we do here at Kaleidoscope. And we work with and study a fair few learning networks around the world, and sort of what we've been quite inspired by is the work of the Innovation Learning Network, which is based out of Kaiser Permanente in the States, which didn't set out in this way, but realized that the key to getting collaborative working across their membership was thinking about how they can cultivate friendships between some of their members. And friendship isn't always the answer when you're thinking about collaboration, but I think is certainly a slightly different conversation to if you're thinking about the structural models. If you're always thinking about, do we need to do merger or federation, it's unlikely that you're going to be thinking about, yeah, but how do we get to this to work for us as people as well as organisations. So I completely agree with that informal point. We've got 2 minutes left, so I might turn to, before doing some final housekeeping, might turn to Ben for any sort of final reflections on the session, and then I'll wrap up. Ben, sort of 58 minutes of great conversation summarised in about 40 seconds.
I guess just to finish by saying that collaboration is difficult. I mean, so I know you're saying it starts with friendship and it makes it sound easy. Actually, building relationships is quite a hard thing to do because it does involve investments of time. And I think one of the things that we can offer through the programme is a process that people can follow that's going to help sort of accelerate that, because there's a frustration I know with people who want to do it that it just takes so long. And whilst you can't take the investment of time, you can at least stop going down dead ends to make sure that it's happening as well as it can. So I really hope we get some people working with us on the programme, because I think it'd be a really exciting journey for us all to go on.
Ben, thank you very much indeed. So it's just my job to say thank you to Ben, thank you to everyone for joining, to say again that we have been recording the session. It's going to be available on the Primary Collaboration website. The address is just there for you to watch that back. You'll be available later on today. We do hope you really are interested, enthused, excited about the programme, and that you're thinking about joining us on it. So again, just the process is, if you go onto the Collaboration Funder Primary Care Collaboration section, all we need at this stage for you to email us and say, yes, great, I want to join, and we'll take it from there. Again, registration opens today. Very exciting. I'm sorry for the lack of balloons and things. But it opens today. It is 20 participants, £3,500 per participant, plus that. And there's that 10% discount for the first 5 registrants. So hopefully it's been an interesting, informative session for you. Very much hope to see you again. If you've got any questions at all, go through the website, send them through, and happy to answer them. So time exactly at 1 o'clock. It's goodbye from me here in London. Goodbye from Ben. And hope to talk to you again soon. Thank you very much all. Do get in contact if you can help. Thank you.